Another thing that you're very good at is looking out for the other person. Let's say that it's nighttime and you're working and there's only two docs in there, Pod A and Pod B. Any advice on that?
Yeah, so if I'm in Pod A, what I try to do, if the waiting room is not so busy, I try to clean out Pod A by latest 1 a.m. and then I move in into Pod B. And then when I become Pod B doc with this second doc, then it's not a fast track patients, it's whatever comes in and we alternate. So that now obviously if it's busy in the front, the waiting room is full and you cannot close Pod A, then you just have to keep on going and seeing all the patients you can.
So you'll still be in Pod B, but you'll go to Pod A.
Yeah, so I do kind of both.
Okay.
Sometimes I do both, and if it's just swamped and Pod A is full, the other doc understands. I cannot just drop Pod A. But what happens sometimes, I don't clean out Pod A completely. There are some patients in there, but I know what their disposition is. They're just waiting for some studies. Then I won't close Pod A, but I will still be in Pod B, and I'll just check in and disposition a couple of those patients later on.
Yeah, that really helps because Pod B can get kind of hairy.
Yeah, I understand. After 2 o'clock when you're by yourself at Pod B, I mean, working it myself, I know how hairy you can get. And one time I had 22 patients to my name, and 19 of them were my own brand new patients. So managing that, a Pod A guy was or girl, I can't remember, was busy, and so managing, I understand how difficult it is. And this is where you also try to utilize as much of your residents and medical students as you can. So what happens in those cases, let's say I'm by myself, the room is hopping, I have maybe one resident and one medical student, that means that I can see 3 people at the same time, technically. So I send the resident to see the sicker person, I send myself to see the sickest, and I send the medical student to see not so sick, and when we regroup, they tell me what it is. With the resident patient, what I do, if it's really sick, I go in right away to see them. If it's not so sick, I have them put in the orders, then I will go see the medical student patient with those orders, and then I come back to see this resident. So that's how I do it. And the sickest person always mine.
Yeah.
So that means within that same time frame, I had 3 patients seen. Now, of course, medical student patients, I have to reevaluate de novo, but I already have an idea what's happening. Resident students, resident patient, I do still have to reevaluate de novo, but they are already physicians, so I sort of trust some of the information. I don't have to completely go into. And sometimes with those, what I do is I say, the resident so-and-so told me that this is what's happening. And I give him the story that the resident told me, kind of regurgitate back. Is this kind of right, or is there any corrections, or is there any other information you want to give me? That takes 3 seconds to ask.
Yeah.
If they say this is correct, I go into the exam. So the information is already there. It has been confirmed by the patient. If there are any corrections, they gave it to me, and my main issue is to do the exam. Again, that takes less than 5 minutes.
So do you have any advice for some of the newer physicians on how to work? Because rushes can be somewhat of a cumbersome place to work. What advice would you give them?
So obviously everybody will develop their own style, and I cannot impose my style on every physician. The advice I give you, number one, is to sort of try to utilize your external resources as much as possible. That's your clerks, techs, nurses, residents, medical students, whatever resources you have, utilize them first. For example, difficult IVs. I know it may take us a long time to spend in the room doing an IV. This is where you ask the most experienced nurse in the room to try, and they're usually very good at it, and they will find something. Okay, central lines. If you are having difficulty with the first attempt, maybe the second at the most, that's when you go to your colleague who has hopefully a more experienced physician and say, can you assist me in this? Because if you are in the room taking so much time doing a procedure, that means your colleague is getting slammed at that same time.
Right.
So if they cannot assist you, see what are other external resources. If it's during the day, you can definitely contact interventional radiology. They will assist you in that. Says, difficult line, I really need help. They'll actually come and do it for you. The other resource you have to know at Rush is the PIC line service. They're available, I do believe, till 9 p.m. every day, Monday through Friday. So the nurse, the clerk can page them for you. So those are the resources you have for the lines, for example. Other things, like I said, utilize residents, but don't wait to hear from the residents to see the patient. That's my biggest pet peeve. I have to see the patient regardless. So if the resident is taking too long, I'm going to be right in there getting that same story at the same time.
So you'll actually barge in?
I do barge in sometimes.
Yeah, okay.
I apologize, Dr. So-and-so. I'm just going to, what I usually say, I would like to listen in so you don't have to repeat your story, which is good for the patient. The residents sometimes get a little flabbergasted, but you know what? It's all about patient care here. And the third thing is, you know what? If the resident is seeing the patient, that means you have time at that time to go see another patient. So don't think that just because you're waiting for the resident to come and tell you, sign up for the other one. So that means at the same time you signed up for two. Don't worry about signing up one at a time. And that's what I see some physicians are doing. They sign for one patient at a time. They do things for that one patient, then they sign up for the next patient. You cannot do that if it's a busy ER. You got to sign up for multiple patients at the same time.
Are you pretty cognizant of how many patients, like the distribution of patients, and so like if there are 5 new patients and the other person is swamped, you grab all of them?
I grab all of them.
Even if it's a middle of the shift?
Yeah, absolutely. So if I see that the other physician is, either resuscitating or obviously have 15 patients to their name, I will pick up all of them. It becomes obviously difficult on me, but I will get through them eventually, so I might not need to pick up. Now, if all the rooms are filled and you picked up those 5, they're not going to bring another 5 at the same time. So you have some time to work on these 5 patients.
Yeah.
And hopefully by that time your colleague freed up and then they can start picking up a few more on that side. Other thing is, what else? How long you spend in the room. I've seen some physicians literally taking 20 plus minutes to see each patient. So I don't know, maybe these are complicated patients. Obviously every patient is different. But you have to sort of limit your time in the room. If it's a patient who's talking too much, try to sort of steer them towards focusing on what is the complaint today. Assess that complaint first, and then if you have time and you want to get the rest of the story, you will have to come back when you have time. You cannot spend 20 plus minutes, unless you're resuscitating, obviously, in each patient's room. It's just not possible in a busy ER. So you have to limit your time a little bit. Limit yourself. Say no more than 10, 15 minutes in the room. And that includes, if you're thinking you have to spend this much time, then log in onto that computer and as you talk, at least put in the order. So this way you are multitasking on that one patient. So if you're spending 20 minutes in one room, 20 minutes in another room, and 20 minutes, then in between you're charting, putting orders in, you're not going to be able to see multiple patients at the same time.
Any tips on how you maintain like patient satisfaction when you're and not making it seem like you're cutting them off?
Right. Obviously, my satisfaction is not 100%, but I am above average for the group. So I'm doing something fine, even with satisfaction limiting. So I always try to sort of be considerate of what they tell me. I explain to them if I have to cut them off. I explain to them what I'm doing, saying, I'm so sorry I have to cut you off on here. I just want to limit your history to what brought you today because, and you have to tell them because you know what, you are very important, but I also have 15 other patients that I have to attend to. And I will review your history in the chart so I'm not missing the information. So I tell them up front. And most of the patients are fine with that. There will be some dissatisfied patients, but they had been over the years, over the last 10 years, obviously there had been some patients who were complaining. I mean, one patient, I'll give an example, came in with Bell's palsy. I saw him in between 2 intubations. So I went into intubate, came out, saw this Bell's palsy, went into intubate and second patient. So obviously I did not spend a very long time with the patient. And the patient did say in his review, the satisfaction survey, that I only spent 3 minutes with the patient. It was a clear cut. Explained to them I can't spend more time with them. Gave them a lot of information. The patient ended up going to another hospital, had a full stroke evaluation. In the end, was told that you have Bell's palsy. Please take the medication that Dr. Purim prescribed at Rush. and his rush chart did not. I mean, his rush bill wasn't as much as his other hospital bill, but the diagnosis was the same.
Mm-hmm.
But yeah, obviously there will be patients who are sort of dissatisfied, but don't be curt with them, with the patients, especially if you know you're not going to spend a long time. If it's something minor, like I had a Pod B busy shift and they brought in, because Pod A was also busy, a toe dislocation. I walk in, I said hello. I kind of tricked the poor patient. I was looking at the foot and I pulled the toe at the same time. It was a momentary pain, but it was done. Mm-hmm. That was the whole interaction with the patient, except the fact she told me how she did it.
Yeah.
Her foot exam was done at the same time as her intervention was done. And when I came out, by that time, I put in for some pain medication, I discharged the patient. So that interaction with the patient, literally less than 5 minutes from beginning to the end. And that's because you have to sort of be conscious which patient you will spend more time with and which patients you will not spend, but it has to average out in less than 10 minutes, mm-hmm. except for resuscitations and sick patients. I am happy to work with individual physicians if there is any questions come up, or if there is some epic questions come up. And I know that lots of guys do the whole charting from typing in, which is another thing that I've noticed from the new group. Do use your macros. Mm-hmm. Create your own macros. It's very simple to do, and if you need assistance with myself or Raul can help you with that. We share our macros, so you can use that. And don't be afraid of utilizing click, click, click function, because these charts were created in such a manner that will give the gist of what's happening. For example, abdominal pain. You will click it, it will tell you how many days, what it feels like, does it go anywhere. And so sometimes typing in just will take that little blurb. Patient came in with 3 days of abdominal pain as above. And as above, it's already clicked and it says all the qualities of this pain. So I think utilizing the click, 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 it saves you time. It gets all the information that you need, and you don't have to write a novel.
Those are great hits. Thanks for sharing that.
All right, very good.
Okay.
Thanks.